Raise your hand if you or a loved one is affected by diabetes. Now imagine being part of the 90% of diabetes patients who lose their sight despite their blindness being entirely preventable. We are Type 2 crew, and today we're presenting Glucase. Glucase is a decision support tool utilizing augmented intelligence. This aims to reduce health disparities by leveraging electronic health records to more efficiently use sparse navigation resources while also keeping equity in sight. Right now, more than 37 million Americans are affected by type 2 diabetes, and this equates to 1 in 4 healthcare dollars being spent on diabetes care. As important as this dollar value is, in terms of quality of life, the cost is even more stark. Hours spent on dialysis, amputated hands and feet, even blindness are all byproducts of this current and lacking system. But this burden is disproportionately shouldered by our marginalized communities. So we created Glucase to address these gaps while also targeting the most high-risk patients. Our product can be implemented in hospitals around the United States to better manage the impact of type 2 diabetes, especially in those communities hit hardest by this disease. To understand the current state of diabetes care, it's important to understand the history that got us here. The introduction of insulin saved millions of lives, but due to a limited understanding of this disease, patients with type 2 diabetes still receive improper care. The advent of medications to treat type 2 diabetes shifted the standard again by providing treatments aimed at this underlying condition. And just as increased understanding allowed doctors to separate diabetes into 2 different types, we now have evidence to show that there are distinct groups within type 2 diabetes itself. This current understanding of this disease is not working for many, and it contributes to worse healthcare outcomes and wider healthcare disparities for our Black and other historically marginalized populations. Today, we present a new approach to type 2 diabetes care and introduce Glucase. Glucase is a decision support tool for the healthcare teams and a resource allocation tool for the entire healthcare system. It will rapidly characterize high-risk patients for complications due to type 2 diabetes and improve providers' capability to coordinate care.
Hey, everyone. So the goal of our work was to use readily available electronic health record data to establish distinct clinical phenotypes of type 2 diabetes and determine the 5-year risks of various complications within each of those phenotypes. To do so, we utilized the All of Us database, which is a minority and female enriched database containing standardized EHR data for over 200,000 American patients. We started with about 200,000 patients in the All of Us database, of which 30,000 had a type 2 diabetes diagnosis as confirmed using Northwestern's eMERGE algorithm. This is a validated algorithm for establishing a type 2 diabetes diagnosis using EHR data that has a 98% positive predictive value. After excluding patients with incomplete medical record information, we were left with about 6,000 patients for use in our final analysis. Using 5 variables from the EHR at the time of diabetes diagnosis, we established 3 unique clinical phenotypes using Cadence clustering, and we then calculated the 5-year risk ratios for various complications within each phenotype. Additionally, using the same 5 variables, we established a TensorFlow prediction algorithm, which was able to predict which phenotype a patient would likely fall into with 89.9% accuracy. Our final step will be to incorporate this TensorFlow prediction algorithm into the Epic EHR platform using the Microsoft Azure development environment and use this to send alerts to providers. We chose 5 variables based on previous type 2 diabetes clustering literature, as well as ease of access for providers. These were BMI, hemoglobin A1C, waist circumference, triglycerides, and HDL cholesterol at the time of type 2 diabetes diagnosis. We calculated the 5-year risks of various complications of type 2 diabetes, but we'll focus on diabetic retinopathy specifically for this presentation. So using these variables, we established 3 clusters through K-means clustering, which we described in the following way. Our first cluster we termed morbid obesity cluster. This had an average BMI of 43.5 compared to an average of only 35.1 across the rest of the sample. We then had the insulin-resistant phenotype, which had a high average HbA1c of 11.5% and was predominantly African-American. They also had a significantly higher triglyceride level at baseline than the remaining 2 clusters. And the late onset phenotype was on average 10 years older at type 2 diabetes diagnosis than the other 2 phenotypes. To demonstrate how a provider can make use of our tool, let's look at the example of Sherry. She's a 48-year-old woman with newly diagnosed type 2 diabetes who's presenting to her primary care provider. She's obese with a BMI of 31.6 and has a high HbA1c of 11.5%. Her primary care provider may be wondering, what comorbidities is Sherry at risk for and when? And what can I do now to prevent them from developing? So our TensorFlow algorithm calculates the probability that Sherry falls within each of the 3 clinical phenotypes. And based off the highest calculated probability, we assign her to the insulin-resistant group. We found that the insulin-resistant phenotype had a 1.7 and 2.3 times higher risk of developing diabetic retinopathy in the next 5 years than patients in the late onset and morbid obesity groups, respectively. Given her relatively high risk of diabetic retinopathy, even compared to other diabetic patients, Sherry would benefit from ophthalmic evaluation for diabetic retinopathy screening. But did you know that 60% of patients with diabetes do not attend annual eye screenings, and minority populations are overrepresented in this cohort? This can occur for a variety of reasons, but it's often because diabetic retinopathy is asymptomatic in its early stages. We therefore propose an EHR tool, which will notify providers if their patient falls into a particularly high-risk group for any of various complications, provides prompts to providers to conduct an Ask, Advise, Connect conversation with their patient, and gives providers the option to initiate pull referrals within their health system. This combination of Ask, Advise, Connect conversations and pull referrals, in which individuals from the underutilized resource are directly contacting patients to establish follow-up, is a well-established method for improving use of underutilized resources. In an Ask, Advise, Connect conversation, providers will ask a patient about their understanding of a disease, advise them as to the best next steps for their health, and connect them to relevant resources in the event that a patient is willing. Importantly, this type of conversation can be led by any member of the healthcare team, like nurses and medical assistants, as shown in previous studies using these kinds of models. In the case of Sherry, we've provided a mock-up here. Epic will send her provider an alert that she falls within the insulin-resistant phenotype and that she's at double the risk of diabetic retinopathy compared to other diabetic patients. It will also provide prompts to assist in an Ask, Advise, Connect conversation if the provider would feel that's helpful. The provider can now ask the patient about her understanding of diabetic retinopathy, advise her to visit an ophthalmologist for screening, and connect her with an ophthalmologist if she's willing to do so. The provider will also be able to select to initiate a pull referral using our tool, in which individuals from the ophthalmology department will be provided Sherry's information, and they can reach out to her directly to schedule a follow-up visit with the ophthalmology department for screening. This can be similarly implemented across various other aspects in the hospital, including the nephrology department, endocrinology department, podiatry, and even neurology, to address other complications of type 2 diabetes. Our tool will empower all members of the healthcare team with the necessary knowledge to conduct an Ask, Advise, Connect conversation and allow all of us to participate in improving patient care.
Ask, Advise, Connect is a proven strategy that has demonstrated its effectiveness. With Glucase, we seek to apply this framework to type 2 diabetes and directly impact healthcare disparities. To do this, we first plan to submit a manuscript for publication. Next, we will meet with EHR Epic support teams to showcase our product and to develop an implementation plan in local hospitals. As multiple members of our team conduct research with the Cleveland Clinic Cole Eye Institute, we aim to collaborate with the clinic and other local partners. And after implementing Glucase and evaluating its effectiveness, we'll expand our algorithm to include other diabetes complications. Sherry needs to see her ophthalmologist, but here lies the problem. Patients who do not have visual symptoms rarely see their specialist, even though these patients will benefit the most from diabetic retinopathy screenings. In addition, Black and Hispanic patients are at 2 to 3 times the risk for diabetic retinopathy compared to their white counterparts, meaning minority patients will benefit the most from the introduction of products like Glucase. Fact, 90% of visual complications due to diabetes are preventable, and we are currently failing patients. Glucase changes all of that. Glucase's target customer includes healthcare systems, and especially those that use a capitation payment model, as they shoulder the risks and the benefits of health outcomes. Our metric of success is an increase of at least 5% in annual eye exams. In Sherry's cluster alone, over 800,000 Americans will develop diabetic retinopathy in the next 5 years. And if even just 5% of these patients attended their regular annual screenings, This would lead to a savings of at least $25 to $41 million. And this is just the beginning. Consider the impact of glucose on both health and on savings when we expand our algorithm to include additional diabetes comorbidities. Through our Ask, Advise, Connect strategy, utilizing the dual push and pull referral mechanism, glucose is a decision support tool for the healthcare team and a resource allocation algorithm for the entire health system. It quickly assesses patient risk for complications due to type 2 diabetes and improves providers' capabilities to coordinate care effectively. Glucose doesn't give the patient a new doctor, it gives the doctor a new patient, all while keeping equity in sight. We would like to thank Northwestern for hosting and all the participants of the All of Us research database for making this research possible. Thank you.
First, so a couple of questions in the Ask, Advise, Connect framework. One of them, we didn't really look at data on completion of screening for ophthalmologic risk for our diabetic population in the retinopathy. What changes in that piece? Because that's our variable, right? It's the clinical decision support tools may be out there with health maintenance programs, variety of EHRs, etc. We can automate annual reminders to say, hey, you should complete your ophthalmologic screening. Now you're adding on the odds ratio, the risk associated with it. How do you convert the next patient? And how does this tool potentially help you actually get the patient to go to their referral? Fully understand, okay, now have the referral be a pull mechanism to get it to an ophthalmology clinic. Those are often also understaffed and don't have extra staff to go reaching out to patients to hope that someone might schedule an appointment.
Right.
How do you close that gap of actually completing this?
So yeah, two comments to address that. So essentially, we're basing our work off of previous work by our institution, which collaborated with Metro Health, and a similar implementation to address use of nicotine cessation resources, specifically the Ohio Quitline resource. So in that model, MAs and nurse practitioners would meet with patients and conduct an Ask, Advise, Connect conversation and kind of gauge the patient's willingness to initiate use of the Ohio Quitline resource for tobacco cessation. And so patients who were interested would then refer to the Quitline, and then individuals from the Quitline would reach out to the patient in a pull referral type of model. And so they actually found that they were able to increase the use of that tool by up to 30-fold after implementing the combination, the Ask, Advise, Connect, and the pull referral. So that's, I guess, one way to address the question. The second way is, as you mentioned, ophthalmology departments themselves can be understaffed. So there's a lot of interest now in providing fundus photography options in primary care settings, where MAs or nurses could actually take fundus photos themselves of patients, and these images can be sent off to larger reading centers on a national basis that can determine the risk of diabetic retinopathy. And recently, the FDA has actually approved AI technology to automatically grade those with pretty high accuracy. So kind of implementing the pull referral system and even encouraging some clinics to start investing in these kinds of fundus photography devices could address that shortcoming.
Something quickly to add is we are already doing the yearly reminders. You know, the primary care physicians are doing their best. They're telling their patients you have to go, but it's not working. Like, these patients aren't going. And something we didn't have time to discuss was diabetic retinopathy progression within 5 years is extremely rapid. This is not the normal progression. Usually it might be 10, 15 years. So if we can tell a patient, you must prioritize this, you have a very high likelihood of going blind quickly, that helps them prioritize, okay, which specialist do I really need to see this year? You know, people care about their vision, so.
That was my question. I was curious about the workflow. And it's great to have all these tools. I'm trying to figure out how do you place this in the physician work. I was curious why you said hospital systems versus specifically a PCP as a starting.
So that's Jacob, you want to switch to the end of the slides where we show how many patients visited a PCP?
Sure.
Yeah. Great. Yeah. So we actually did some analysis and looked at what proportion of patients visited their ophthalmologist and what proportion visited their primary care provider. So we saw that the majority of patients, over 90%, did visit their primary care provider. So this tool is primarily targeted at them. They're the first step on the stopgap and initiating the further processes. But we're providing alerts to that primary care provider and then giving them the power to initiate a full referral to the subspecialty providers. So it is, you could say, targeting the primary care provider, but it's involving the system as a whole because it initiates full referrals into other departments.
You have an online question? Go ahead, Gaz.
Yeah. Okay. So firstly, very good articulation of the problem and approach. And I like the way you presented the outcomes and the measurement of results. Question, there are several studies published on this and several models already built on type 2 diabetes particularly. Can you talk about how you're building on existing papers and research, both from a data standpoint and any other already available models which have been published, how you're building on top of that?
Yeah, so I think our study is unique because our population is very diverse. So our data is specifically enriched for minorities and women. And a lot of the studies, especially the Outquest clustering study in type 2 diabetes, is specifically in like a predominantly white population that's of higher income. So our data is of a higher quality to begin with and more diverse and more representative of the population in the US. So I think our algorithms as a result will be more applicable to a broader population.
And a lot of some of the variables that were used in previous studies are not as easily accessible to the EMR on a general basis. Our variables that we used are 5 readily accessible ones like BMI and HbA1c, which are gathered for most patients, especially those with diabetes.
Mm-hmm. Okay. Yeah. Just an observation there. Even if your data is more diverse, it'll be useful to look at some the prior studies to see which factors are the key predictors for comorbidities and other conditions, because there is a signal that you can glean from the prior studies, and you can always enrich that.
Thank you. Thank you.
Thank you.
So maybe one last question for you is, what do you see are your biggest risks to success in implementing this type of a product? And then 2, what, if any, feedback have you received even on your initial proof of concept demo from your target customers?
So a lot of feedback from primary care docs are, we don't have time to do another thing. So our response is, anyone on the healthcare team on the primary care side can do this. So MAs or other members of the healthcare team can, ask questions to fill in missing data or order tests, or even provide some of the Ask Advise Connect model. So it can be dispersed amongst the entire healthcare team. And it doesn't just focus on the primary care provider. I think a big challenge is timing, especially in high volume clinics where you might only have 10 minutes to see a patient. There's a lot of competing things that you have to go over with those patients. So just like working this into the workflow and getting providers comfortable with the Ask Advise Connect framework and those kinds of things, I think are very challenged. And then also some of the social determinants of health barriers such as transportation, I think are a huge problem. So
if I can add to that. So we were able to set to clinically phenotype and generate this algorithm with only about 6,000 patients. I believe one of the important things we can do is when we give this, when specific hospital systems use this, they can train it on the data and on their patient, the EHRs, which has much more than 6,000, so that every hospital system will be able to use their own data that's informed by the patients that they're treating, and then generate specific algorithms, specific phenotypes that are tailored for that patient population. Because I would say one of the largest considerations for this classification, we don't want to tell patients wrong, and we don't want to use our physicians' time inefficiently. So, but by hospital systems using their own data to inform our algorithms, we should be reducing that the risk of misclassification.
Also, like that one last thing. So some of us do research with the Chief Medical Innovations Officer at Metro Health Cleveland Hospitals. And so we met with him before creating our presentation and discussing it. He feels it's a feasible implementation as well. And he's implemented similar tools within the EHR at Metro Health.
Yeah. And I work on our current project doing something similar in dentistry, and we've been able to implement it successfully. So.
You mentioned integration with Maatouk for Epic. Recently, we heard that there's also going to be like some large language model integrated with that. How would you see that play out in this whole bigger picture?
So yeah, it's a tool to implement in Epic, but then I think our tool is even generalizable to like any EHR. So we're not trying to like pigeonhole ourselves into Epic, but we chose Epic and you talked about Microsoft Azure because it's an easy way to get it into Epic and create alerts for our health systems we work with in Cleveland. And they're all on Epic. So that's kind of why we focused on that.